In this part, we'll talk about airway management decisions. Some of the things we need to think about as we focus on establishing and maintaining the advanced airway. So we talk about advanced airways, a lot of times we conjure up this image of the kind of uncomplicated arrest. We think about that cardiac arrest patient. When we walk in the door, first responders are already doing CPR. They've got the patients being bagged, using a good, high-quality two-rescuer technique with one practitioner focusing just on that mask seal. Of course, they've got an oral airway in place. Ventilations are slow, with bag compression lasting about a second. And they're stopping CPR, make sure those ventilations get in, and we're not overpressurizing the stomach. In this scenario, we look at the patient. Clearly, there's a need for an advanced airway. So the clinical decision-making scheme for this patient, pretty straightforward. We need a definitive airway that can be placed quickly and have no breaks in CPR. For that application, a supraglottic airway is probably the best. We have blind insertion, we have a rapid technique, and we don't have to stop CPR to get it done. The equipment setup hopefully include lubing the airway. We should have that suction on, running, device to secure the airway should be in place so we can quickly attach it. And capnography line is attached pre-insertion so we get first breath capnography. So as long as the patient has no known contraindications to the specific supraglottic airway we're looking at, the procedure should move along pretty quickly. Confirmation of the airway in place is pretty straightforward. We look for rise and fall of the chest, auscultation of the epigastric and lung sounds, and of course, that first breath capnography. Unfortunately, airway management is not always quite that simple. Lots of things can affect the management, lots of things can affect the insertion, and of course, lots of things can affect our downstream management once the airway has been placed. CPR itself is a big one. The patient's moving. It's hard to get the airway seated sometimes, especially if you're trying to visualize the glottic opening with endotracheal intubation. That may require stopping CPR, which is something we don't want to do. So that makes us focus more on supraglottic airways, which is why we prefer them. Problems with patient access can affect the way we practice medicine in this case. If the patient's in the back bedroom, in a narrow hallway, it makes it difficult to get practitioners around and sometimes get the space required to do those advanced airway techniques. We need to think about these things when we start working the arrest patient. Is it better to start CPR in a place where we can't work very well, or to hold off for a few seconds and move the patient to an area that's going to give us more real estate? The physical surroundings can affect our plans. For instance, if we're outside, we decide to use an endotracheal tube, it can be very difficult to visualize the structures if it's extremely bright out. Physiologic conditions can certainly affect our management. Trauma is a big one. If there's damage to the upper airway or the facial bony structures, it can be difficult to place the airway. It can be hard to gain access, or again, to get a good visualization of cords when we're trying to place an endotracheal tube. Vomit is one thing we certainly see a lot in cardiac arrests. That makes management of the airway very difficult. And there's other physiological issues that can hamper our success. Maybe anatomy is not where we think it's going to be. We miss our landmarks. Other issues can come with patients who may well be breathing. They just don't happen to have a gag reflex. Those patients can still be candidates for advanced airways. And we have to consider the proper adjunct. So the chart on the right of the screen looks at our airway successes for the first quarter of 2015, January, February, March. The first line looks at the total number of patients that we attempted any sort of advanced airway on. And we excluded those patients who may have been in cardiac arrest but only got a basic airway for whatever reason. There were a couple of those throughout the quarter, It included patients who may have had ROSC before an advanced airway was placed, sometimes by the fire department, sometimes when ALS first arrived, or a handful of patients who had CPR done prior to termination for hospice. The middle column shows a number of first-time successes. When we looked at that, if a airway got placed but subsequently failed for whatever reason, either it wasn't seated properly, we saw pulse oxes dropping, carbon dioxide levels dropping, and the airway was then removed for a different airway, we considered that to be outside of the first-time success. And then the last line is that percent of first-time success. So you see in January, not bad at 87%. February, a small fall off to 59%. In March, a rebound to 73%. Generally, these airways were some sort of supraglottic, and most of those supraglottic airways being Kings with an occasional combi tube in there. There were some endotracheal tube intubations, and we had some problem with, and those also show up in these stats. The interesting thing here is that what we would expect with a supraglottic airway is in the high 90s, 97% is what we see naturally in the literature. So this is a pretty small sample size, just 3 months. And because our total number of patients is low, this variation from month to month is probably not statistically significant. What it does show, though, is an overall trend of airway successes being lower than we would anticipate. So we want to focus on things that can help us improve our airway success. 3 major points that we'll look at. Identification of the difficult airway. That will help us identify those patients who may be tough to intubate or have problems with supraglottic airways. It'll help guide the practitioner in the proper direction for procedures and device selection. Continuing on with that, selection of the proper airway for that patient certainly can be the difference between positive and negative outcomes. And finally, we'll look at some of the planning that needs to go in to make sure we have a successful airway encounter. One thing that's important is the ability to predict a difficult airway. If we examine a patient, we think right away it may be tough to visualize that an endotracheal tube might not be the best solution. Similarly, if the patient falls out of the weight or height range for supraglottic airway, we may have to go to the endotracheal tube. So there's lots of studies that have been written on the different methods that are out there to predict a difficult airway and determine if a patient is going to have a problem prior to performing the intervention. Now, some methods are better predictive than others. No test can certainly identify all the airway issues until we're in there doing the job. So we must be able to quickly change and adapt to those previously unknown challenges. It means we must have all of our equipment out and staged. We need to have suction running and at the head in case there's vomit in the airway. We need to have our tube tie pre-strung so that we just pick it up and put it in place. We need to have someone whose job has been assigned the stethoscope so that they can check the epigastric and lung sounds on the first series of ventilations. Another thing we need to do is make sure we retain the bag valve mask and oral airway. That someone's assigned specifically to handle those. In case the advanced airway attempt for whatever reason needs to be abandoned, we can change back to the BVM and oral airway rapidly with a minimal amount of time without ventilations. And that backup plan needs to be articulated to our team prior to the attempt. So if we have to abandon the attempt, everyone understands what their role is to get back to ventilations as quickly as possible. Some factors that may predict a difficult airway. Some factors that may influence the outcomes of that difficult airway. Certainly CPR. As first responders doing compressions, the patient's moving, it can be very difficult to visualize anatomy and tough to place an endotracheal tube. Naturally, you don't want to stop CPR. So in that case, the most appropriate airway is probably going to be some sort of a supraglottic airway. Vomit and aspiration. If the oral cavity is filling up with vomit, makes it very difficult to visualize for endotracheal tube. This can also cause problems for the supraglottic airway. If the vomit's in the pharyngeal space, our first couple ventilations can just help drive that into the lungs. The opening of the mouth. Can you get their jaw to open up wide? The mandibular protrusion test, you see a graphic there on the right. That helps us sometimes determine how far the jaw is going to be able to move so we can get in and visualize the cords well. And mandibular joint flexibility. The size of the tongue. If they have a tongue that takes up a large percentage of the oral cavity, it's going to be slightly more difficult to make sure that's displaced, especially problematic with endotracheal tubes, but also a challenge with supraglottic airways. Cervical spine flexibility, the length of the neck, the sternal-mental distance, you see a graphic for that. It tends to be a good predictor of ease of intubation. The longer that distance is, commonly, the easier it is to visualize cords. So we've looked at things that might make a particular patient have an airway that's difficult for one airway adjunct or another, but what airway adjuncts should we be thinking about? For the cardiac arrest patient, airway selection is relatively straightforward. I think the supraglottic airway makes the most amount of sense because it really limits the time that we have to stop CPR. The supraglottic airways we typically use can be put in with no break at all in CPR. They're inserted blindly. We don't have to worry about getting good visualization of the anatomy. The first choice for supraglottic airways should be the iGel. The iGel is new. We'll have additional trainings in this online module to roll that iGel out and get you comfortable with it before we bring you in for hands-on training in the near future. The backup to the iGel would then be the CombiTube SA. The CombiTube is also a supraglottic airway. It's easy to insert with minimal to no breaks of CPR. We'll have an additional module to refresh everyone on CombiTube use. Endotracheal tube intubation would then be considered a backup to the supraglottic airways. I think it's important in a cardiac arrest patient to make this hierarchy. Again, it decreases the amount of time we have to stop CPR. It's important to remember that endotracheal tube intubation is designed to be through an oral tracheal route, not a nasal tracheal route, as that has not been selected in the protocols here in Kalamazoo County. And of course, if all those things fail, a good old-fashioned oral pharyngeal airway with a bag valve mask. The other type of patient we want to talk about is a respiratory distress or respiratory arrest patient. These patients may be apneic, or they may have some degree of respirations that clearly don't have a gag reflex. The common patient that comes to mind might be a CVA patient. They may present as unconscious, but they are breathing. When we check their soft palate, they don't demonstrate a gag reflex. On these patients, the practitioner is able to pick from any of the approved advanced airway adjuncts. And it's both practitioner and patient dependent. Depending on the scenario, you may use an iGel, a CombiTube SA, or an endotracheal tube as your first line airway. Next, we want to talk about some planning. Before we begin our advanced airway attempt, we want to make sure a few things happen. We certainly want our patient to be pre-oxygenated. And during that time, we need to get a base set of vitals. If we can get a blood pressure, a pulse ox, for those that aren't in cardiac arrest, that's important. For all of our patients, if we're using a bag valve mask, before we switch to a new airway, we should be checking breath sounds. This may help us to identify an underlying pathology. It also will help make sure that the advanced airway is placed properly by having a good before and after procedural check. We need to set up and stage our equipment. The tube tray should be strung and in place, making sure that we are able to capture first breath capnography. Have the stethoscope at the ready, suction on and running. We also need to develop and then share those contingency plans. Think about what-if scenarios for the attempt. If there's too heavy of vomiting, if I can't visualize cords for endotracheal tube placement. Make sure that backup plan is in place and that other people know what it is if we have to abandon the attempt. This all goes back to the theory that the only true airway failure is not recognizing that we have a bad airway. The last thing we want to talk about is our quality improvement program. So each advanced airway use in Kalamazoo County is flagged for review. We get daily reports of those use from the State Image Trend Repository, and we do monthly cardiac and respiratory arrest reviews for all those patients. Our review points include things like the clinical indications for the airway, the appropriateness of the specific airway used for that patient. If the airway was replaced or otherwise failed, what corrective measures were taken to ensure success in future attempts? And of course, we always check for the protocol required documentation. This list provides all the points that are defined in the protocol that each report that utilizes advanced airway should have in it. The size of the airway used, the number of attempts, the suctioning required before placement, ventilation compliance, rise and fall of the chest with ventilation, that capnography was used, and what that capnography reading was, the quality of your lung sounds, the absence of any epigastric sounds, what method you used for securing the airway, any complications that may have arisen out of the procedure, and whether or not gastric decompression was performed. So in conclusion, the management of the advanced airway takes an understanding of both the anatomy and the device mechanics to make sure we have the appropriate airway. Good decision making can improve those procedural success and patient outcomes. And the quality improvement of the airway use help us to improve our overall system performance. If you have any questions about this presentation, you may certainly contact Bob Hale, the EMS Clinical Coordinator. Now that you've completed this section, you can go on to the unit quiz and the final exam